apolipoprotein B carries the bad molecules of bad cholesterol. I really think retin A and the vitamin C serum should be sort of staples in people's skincare. So high levels of LPPLA2 are very indicative. So pesticides in produce is a huge, huge problem for HSDD, which is female low libido. That progesterone is so critical for so many other things, including bone, brain, immune cells.
Welcome to our Q&A highlights. Q&A sessions are recorded every month, and our enhanced members get an exclusive opportunity to ask questions from one of cellular medicine's brightest minds, Dr. Elizabeth Yurth. Get a chance to ask your questions by becoming our enhanced member at bli.academy/memberships. You also get access to our content library full of tips, articles, videos, lectures, previous live Q&A sessions, and more.
There's a nice little window of optimal cholesterol between 180 and 240. That brain size is bigger, muscle size is bigger. Less than 180, people had less, so think of it as a U-shaped curve like this. So basically, it's not that, the people at 160 are horrible, but they're starting to creep that direction, right? And the 140 levels where the cardiologists love you to be is not good for your brain nor for your muscles. So at 180 to 240, but remember, it's key to know what makes up that cholesterol, okay? So there is good cholesterol, not just HDLs and LDLs. HDLs are not all good. LDLs are not all bad. So what you really want to look at is the apolipoproteins. So apolipoprotein B carries the bad molecules of bad cholesterol. ApoA, the good cholesterol. Look at that ratio, the B to A ratio. If that's less than 0.6, you're probably pretty safe. You also want to look at the triglyceride to HDL ratio. You also want to look at Lp(a), genetic risk factor. If somebody has a higher Lp(a), I'm going to push their ApoB down even further. So there's a lot of nuances. This is why I think you need to work with a good functional medicine provider who understands cardiology, right? Because I think that there's a lot of nuances to treating cholesterol appropriately. So I think the big thing is skincare really begins from the inside out, right? I think we put a lot of stuff on our skin and we have to really focus a lot more on what we're putting inside our bodies. So when you're eating high sugar foods, right, then you're going to get glycation. Think about like if you put meat out on a counter and let it sit, what happens to it? It gets that really crystallized appearance to the base of it, right? Same thing happens to your skin if you're getting a lot of glycation. Also using hydroxytyrosol. Hydroxytyrosol is found in good olive oil. We know that hydroxytyrosol neutralizes a lot of the free radicals, so it helps protect the skin cells from some of the oxidative damage, like the sun damage, things like that. I do love GHK copper, but it's thickening collagen. It's a slow over time kind of thing. I think it's something to keep with because I think in the long run, it is doing good for you systemically and from, just overall skin perspective. And then don't forget, I really think retin A and the vitamin C serum should be sort of staples in people's skincare. What LPPLA2 is, and this test is either called PLAC or LPPLA2, same thing. But what LPPLA2 is when you have high phospholipase A2, it's produced by inflammatory cells, especially macrophages and monocytes. And these are white blood cells that are involved in the immune response. And these cells, these macrophages and monocytes, when they're activated, release this polylipase A2, and that polylipase A2 then binds to LDL particles that are being carried through the bloodstream. And then when the LDL particles get oxidized, because there's a lot of oxidative stress going on in this person too, then the LPPLA2 starts breaking it down and creating what are called foam cells and creating plaque. So high levels of LPPLA2 are very indicative or suggestive that that person is forming atherosclerotic plaque. It is, to me, the most worrisome marker when I'm looking at people's cardiac profiles. When you look at pesticides in produce, huge. Think about your sort of thin-skinned fruits like strawberries or strawberries, spinach, apples, grapes. They have a lot, very high pesticide levels. You want to be more conscious about making sure those are washed with something like baking soda, because that's going to have a better than just water to get rid of the pesticides. Obviously, buying organic whenever possible is going to be important, but even organic foods are a problem because the rainwater. So if there's a non-organic farm just up the road from an organic farm, that rainwater washes down and the organic farm gets the same pesticides. So that's where we see very high levels of Roundup, glyphosates. And so pesticides in produce is a huge, huge problem. It's hard to get away from. Organic, consider growing your own. So if you can, I know Shannon, who works with us, has a garden during the summer. I know Emily does, who works with us. So I think if you can grow your own fruits and vegetables, I have a horrible black thumb, so I'm not so good at that. But if you can, do it. And throw a little humic acid onto your soil, because that's going to actually bind some of the glyphosate. So if you throw humic acid on the soil of your garden, that's helpful. Heavy metals are another big problem: mercury, lead, cadmium, both in fish like swordfish, shark, tuna. But lead and cadmium are found all over soil. So they're found a lot in our vegetables, and even a lot of chocolate has high cadmium levels in it. So avoid eating mercury-laden fish. Look at cutting swordfish and tuna and shark, and stick to the smaller fish like salmon and sardines as better choices when you're making that choice, because mercury is high in about 50% of the patients I tested in. So it's a big problem. If you can, use a water filter that filters heavy metals. So you want an NSF certified filter for lead reduction. So I would highly suggest, if you don't have a filter water system into your house, that's something you invest in. Addyi, for those of you guys who don't know, came out in about 2015 and was used to treat hypoactive sexual desire disorder, or HSDD, which is female low libido, which is a huge problem. I think in my practice, trying to match female libido to male libido is really hard. Or even after people are done having children, trying to get the libido of women matched to men is really difficult. And that's going to be a really sore point for marriages. It's, so I have a lot of women coming to me for this problem. So Addyi came out to solve this problem in 2015. It's an interesting drug, because one of the things we know is if you have too much serotonin, right? Too little serotonin, you get depressed. But too much serotonin, one of the things that can happen is serotonin actually will reduce sexual excitement. So that's why some of the serotonin uptake inhibitors that we use for treating depression will create a problem with sexual desire. So Addyi actually blocks receptor agonist 1A, and that actually lowers serotonin a little bit. It then upregulates what's called a serotonin receptor 2A. So it's an agonist to 1A, so it upregulates 1A and it downregulates 2A. So what it does is it kind of corrects the imbalances in neurotransmitters. It makes dopamine, norepinephrine, and serotonin more balanced in hopes that we can improve sex drive. And in reality, it sounded good. Didn't really work that well. When you look at the data, it improved the efficacy, that women reported having 1/2 additional satisfying sexual event per month. I don't know what 1/2 means, but they had 1/2 additional sexual event per month. And over 50% had severe side effects of dizziness, drowsiness, nausea, and fatigue. So for 1/2, whatever that means, sexual event, to have all those side effects, it really has not been a useful drug. Number one, I'm going to dose progesterone at whatever dose I need it to be at the right dose for that person by their labs and their symptoms. Okay. There is a slew of people. Myself, I would never tolerate 400 milligrams of progesterone. I would be dead asleep all the time. I'd feel sluggish and horrible. So, but there's women who feel better on it, and their labs support that that's the right level for it. When we do a Dutch test, we see a nicely matched progesterone estrogen ratio. So basically, I think there are women who I need to go up higher on. Well, what about the woman who says she's sensitive to progesterone and can't take it? I have a lot of women who fall into this category, and it's frustrating because if I want to use estrogen, I really need progesterone along with it, as well as the fact that progesterone is so critical for so many other things, including bone, brain, immune cells, joint health. So I really want to get some progesterone into people who are low. So I think that's where sometimes you have to really play with trying to say, well, maybe if I use a little bit of oral and a little bit of transdermal, that's going to work for them, right? Or I microdose it a little bit more. I use smaller doses where they're not we use progesterone primarily at night orally because it makes people sleepier. Transdermally doesn't. So you can sometimes microdose transdermal a few times throughout the day, or even microdose oral, because at a low dose, it's not going to cause the drowsiness. So you can microdose smaller doses throughout the day. Sometimes they're better tolerated for people. So I think that's one of the options. I do like to really keep working on that project and trying to get progesterone levels up, because I think it's such an important hormone for everything. Teriparatide, which you guys might know as either Tymlos or Forteo, is a sort of synthetic parathyroid hormone. It's a peptide that acts like parathyroid hormone, and it is a marvelously anabolic bone building peptide, and it works very well. And it works very well, not just on other bones, but on the jawbone. So it builds bone everywhere, including your jaw. There's about 11 studies. They were all included in a review article that showed enhanced bone formation in osteonecrosis of the jaw, in chronic periodontitis, in osteointegration of dental implants. I think it is very underutilized by dentists. For those of you who don't know what TPE or therapeutic plasma exchange is, basically as we get older, we're going to accumulate more damaged proteins in our blood. So, your blood is basically this nourishment for your cells, and the health of your body is really influenced by the health of your blood. So as I accumulate more toxins in my blood, those toxins get to my cells, they get to my organs, and they're going to create problems. So what therapeutic plasma exchange does is it basically takes out your own plasma. So we're removing a bunch of your plasma, which is full of these harmful substances, right? And then we put back a combination of usually sometimes plasma, sometimes it's more just some replacement fluids like lactated ringers, albumin, sometimes some other regenerative promoting factors. So basically you're just kind of putting back and you're re-diluting the blood so your blood volume stays high. You're not really replacing, because getting somebody else's plasma, you'd have to do the plasma match and all that stuff. So you basically just rehydrate the person. Metformin, which was, proposed forever to slow aging. Now we know that when you add metformin to exercise, it actually antagonizes the exercise-induced improvement in insulin sensitivity and cardiorespiratory fitness. There's another study showing that it impeded muscle development in elderly people when they were on metformin. So I think you are undoing some of the benefit. Remember, you need a lot of mitochondria, healthy mitochondria, to exercise, to form muscle, to improve cardiorespiratory fitness, to make NAD. So if you don't have that, then you're not going to get the benefits of exercise. So I think metformin might be utilizable, sometimes cycling it, so going on and off of it. Statin drugs might be used at very low doses for some purposes. But again, you have to be cautious with these drugs because you have to remember they are mitochondrial toxin. Statins particularly have a very interesting data showing that they have really toxic effects on muscle cells. The cardiologists love them, I know. And I think sometimes they might be, you have to sort of deal with somebody who maybe that's their only choice, but you have to be careful with these drugs.